You're listening to Medscape's In Discussion series on multiple myeloma, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Joseph Mikhael. Dr. Mikhael is a professor in the Clinical Genomics and Therapeutics Division at the Translational Genomics Research Institute, an affiliate of City of Hope Cancer Center. He is also the Chief Medical Officer of the International Myeloma Foundation. Dr. Mikhael is a consultant hematologist and Director of Myeloma Research at the Honor Health Research Institute, where he conducts Phase 1 clinical trials. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, this is Dr. Joseph Mikhael, and welcome to Season 2 of the Medscape In Discussion Multiple Myeloma podcast series. Today we are discussing a critical question in myeloma that I would argue has really come to a head over the last several months, and it is, should we treat smoldering multiple myeloma? And I could not think of a better guest to have discuss this topic with me than the world-famous Dr. Peter Voorhees. Dr. Voorhees is a hematologist and indeed a professor of medicine in Charlotte, North Carolina, works at the Levine Cancer Institute and leads the plasma cell program there. So Peter, welcome to Medscape In Discussion Multiple Myeloma podcast.
Thanks for having me, Joe. It's wonderful to be here to discuss this rapidly evolving topic.
It is. I think by the time we're finished this podcast, there may yet be another study done in smoldering myeloma. There seems to be so much going on here. But let me just set the framework here. I don't want to get into too much historical data. Having worked at Mayo Clinic for years, it was always built into us to understand the history of smoldering myeloma and how Dr. Bob Kyle, essentially created this category of myeloma where we know that on the one hand, up to 5%, if not even higher, in individuals like myself of African descent, and that's also something that you are leading and studying that we can discuss another day, have MGUS, have some evidence of a monoclonal protein, but at a very low level. Obviously, at the other extreme, we have people with true active multiple myeloma, characterized by the now slim crab criteria, the artist formerly known as the crab criteria. But there is this in-between space of smoldering multiple myeloma. And the reason why that area was sectioned out was, even though it's hard to draw concrete lines between these different categories, there was clearly a group of individuals who had a higher amount of monoclonal protein than MGUS patients. We're not quite yet at myeloma, but we're at much higher risk of developing myeloma. And interestingly, even within smoldering, we now have so-called high-risk smoldering and standard risk smoldering. And I'll be asking you in a minute, Pete, about how we can make that distinction, or what should the clinician know to make the distinction between the two. But where there has been this equipoise and this challenge is, do we treat people? We don't, for almost every other cancer in the world, wait until someone has a lot of organ damage to treat it. We treat what we see histologically. But because MGUS is so common, we don't want to overtreat, but at the same time, we don't want to undertreat. And that's really the nature of our discussion today about how we think about treatment. But let me ask you, Pete, in just a simple kind of approach, how do you, in your mind, distinguish between smoldering myeloma and so-called high-risk smoldering myeloma? What are the key features that makes you a bit more concerned that someone's closer to the myeloma spectrum and may indeed need treatment?
So I think, at least in the current clinical environment, there's a couple of things that you can use to assess risk of progression to active myeloma. So the first is what previously was referred to as the Mayo 2018 criteria for high-risk smoldering multiple myeloma, and has since been validated by the International Myeloma Working Group, which is this 2220 criteria. So essentially what you're looking at there, do you have more than 20% clonal plasma cells in your bone marrow? If yes, you get a point. Do you have an M spike that's over 2 grams per deciliter? If yes, you get a point. Is your affected to unaffected serum free light chain ratio greater than 20? If the answer is yes, you get a point. And if you have 2 or 3 of these features, you're considered at higher risk of progression to active multiple myeloma. And what does that mean? It means that essentially within 2 years, you have a roughly 50% likelihood of going on to developing active multiple myeloma. And I think that the community and KOLs in the field have felt like that is a high enough risk to justify the risk of potentially intervening for those particular individuals. The other thing that I think requires a little bit more study and better characterization is this evolving phenotype of smoldering multiple myeloma that we talk about. So you have these patients, you've established that they have smoldering multiple myeloma, and perhaps they're not even considered high risk at initial diagnosis, but their M protein is gradually increasing over time, or perhaps their affected to unaffected serum free light chain ratio is increasing over time, or their bone marrow plasmacytosis is increasing. So that is another group of patients that's at higher risk of progression to active multiple myeloma. But when I say that we need to better refine that whole piece of it, I think we need to have a better understanding of the pace at which these things rise that really relegates you to that high risk category. There have been some nice studies looking at that, but I think we need a larger data set to really wrap our brains around that piece. But this evolving phenotype, I think, is going to become increasingly important in the years ahead.
Yeah, I'm really glad you highlighted that because, so sometimes I use as an example with my patients, and maybe because, I'm a runner and I enjoy running, although as I'm getting older, I'm clearly slowing down. But I've often said, smoldering myeloma is a little bit like running towards a cliff, not to be too fatalistic about it, but there are two features that become really important: how far away you are from the cliff, but also how fast you're running. And it used to be until 2014, we defined myeloma by the crab criteria, where literally you had to have fallen over the cliff and had organ damage. But when we set the limit of the SLIM criteria, greater than 60% plasma cells, involved over uninvolved light chains of greater than 100, MRI findings of more than one focal lesion in the marrow, it's almost like we drew a line, let's say 50 feet short of the cliff, and said, look, if you're getting this close, we really should treat you like true active myeloma. We're now talking about the space a little bit further away than 50 feet. But if someone's moving quickly, as you've said, we want to be careful that we intervene. And so I think you've really beautifully described the 2020 criteria. And I think that's probably what's most accepted now. Before we dive into probably the most practice-changing clinical trial of the last year, the Aquila trial, I do have to remind us that we have had some clinical trials before that have looked at the principle of trying to treat smoldering myeloma. Now, of course, I can put 10 myeloma doctors in a room and I'll have 12 opinions about how to approach this. But one of the concepts was, well, if you do catch a disease so early, maybe by just giving the patient a small amount of treatment for a defined period of time, maybe you can delay that progression, if not even potentially cure a fraction of patients. The other philosophy of treating smoldering myeloma is to say, well, look, listen, you're getting so close to that cliff. Let's just give you the full treatment of myeloma and maybe we can cure it. And those are sort of two different philosophies that I think are going to come out of our discussion today. But in that first philosophy, where we try to use limited treatment for a period of time, we had a couple of trials. We don't need to go through the details of them. One came from Spain and one was an American study where patients were given lenalidomide, either lenalidomide dexamethasone or just lenalidomide alone. And that really kind of divided the myeloma community, Pete. We had some people who said, oh, no, we should treat these people, others who didn't. What was your take on the lenalidomide studies?
So I think that both of those studies were incredibly important proof of concepts that you could potentially intervene in this space and affect the natural course of the disease. So I think in both instances, both studies very nicely showed that using lenalidomide with or without dexamethasone delays progression to active multiple myeloma. I think that that's quite clear. These were relatively small studies. And in hindsight, there are some study design issues that people have raised over the course of time, which has led to a lack of adoption of this type of approach in patients. In the Spanish study, there was lack of advanced imaging, which is used fairly routinely. And I would certainly encourage people to pursue whole body PET CT or low dose whole body CT or whole body MRI imaging to assess for or evidence of lytic bone disease or early bone lesions of multiple myeloma that could certainly influence treatment. That said, in the Spanish study, the median time to progression in the observation arm was 2 years. So they identified their high-risk smoldering multiple myeloma patient quite well. And the US study, I think that the critique largely was it was a much more heterogeneous group of patients, some of which had low risk or intermediate risk smoldering multiple myeloma. So when you look at those that were at high risk of progression to active multiple myeloma, there was a clear benefit with regards to progression-free survival with the lenalidomide, but it was a very small number of patients. And as you well know, lenalidomide is not that easy to take, and it's particularly not easy to take for somebody who has no symptoms of their disease. If you come in, with severe back pain because you've got active myeloma and multiple compression fractures, you're willing to take on a little bit of fatigue, a little bit of diarrhea, a little bit of muscle cramping, maybe a little bit of a rash from lenalidomide. But if you have no symptoms, and then all of a sudden, you've got a little bit of brain fog, you've got some fatigue, you've got some diarrhea, that's not going to really cut the mustard. So I think that they really established the possibility of intervening in this space. We just need to do it in perhaps a better way.
Well, I mean, what a perfect segue that you brought us to, Dr. Voorhees, into a study. If only there were a study with perhaps a more easily tolerated drug given, initially weekly and then every other week and then once a month out for 3 years to see if people's quality of life is not that adversely affected, and yet can it affect their progression-free and even overall survival? Of course, I'm talking about the Aquila clinical trial, which compared patients receiving just active monitoring, and as you duly noted, with good imaging, with bone marrows every 2 years, imaging once a year, versus giving them single agent daratumumab in the typical way we would give it out for essentially 3 years. And I would argue that this study has really changed our practice. What was previously proof of principle has now really been proven in a large phase 3 randomized trial, specifically looking in that subgroup that you mentioned, that high risk, maybe not as high risk as some defined high risk, as the control arm was a bit more than 2 years of progression-free survival. But I would love your take on this. What was the real outcome of Aquila, and really what does it mean for our clinical practice?
Aquila, was a phase 3 study, as you pointed out, that looked at daratumumab versus active surveillance for patients felt to be at high risk of progression to active multiple myeloma. Now, to your point, the definition of high risk smoldering multiple myeloma has changed over time. And as we discussed earlier, the Mayo Clinic kind of paved the way in 2018 for this 2220 criteria that was subsequently validated by the International Myeloma Working Group. In Aquila, you had to have 10% or more clonal plasma cells in your bone marrow, and then one or more of a number of different factors, several of which aren't necessarily incorporated in the current criteria for high-risk smoldering multiple myeloma. The other important piece is the definition of active multiple myeloma has also evolved over time. So now we've got the SLIM criteria for active multiple myeloma, where you have more than 60% plasma cells in your bone marrow, where you have more than one focal bone lesion by MRI imaging, or, you are affected to unaffected serum free light chain ratio, is above 100. So the primary endpoint of Aquila was progression-free survival to active myeloma as defined by SLIM and CRAB criteria. So in this particular study, the primary endpoint was clearly met. So there was a roughly 50% reduction in the risk of progression or death, most of it progression, for those patients receiving daratumumab. And it's important to note, and this is one of the things that we debate, yes, there were a large number of people who really the prevention was to SLIM criteria, but there is also a clear difference in the rates of progression to CRAB criteria as well. The important thing about preventing SLIM criteria is that these are patients who are at imminent risk of going on to develop active multiple myeloma. And in this current day and age, we treat those patients, if they're fit, with 4 drugs, potentially transplant, and an extended period of maintenance therapy. If they're frail, perhaps it'll be a 3-drug regimen, which will be extended until disease progression or the emergence of unacceptable side effects. So I would argue that there is some clinical value to delaying progression, whether you define it by SLIM criteria or CRAB criteria. But this was a very well conducted study. It was larger than the other two we talked about. It was roughly 200 patients in each arm. To your point, we did annual PET CT imaging and MRI imaging of the entire spine, on a yearly basis. We looked at bone marrow examinations every other year. These patients were having serologic and urine studies for their smoldering myeloma on a regular basis. So this was a very rigorously followed group of patients.
So that's impressive. It's really amazing. We knew, of course, the study was being done, but I'm just so thankful it was done so systematically, so carefully, and maybe even a bit more inclusively in terms of definition of high risk, which in a study of this magnitude is helpful as we try to apply it. I think it's fascinating how you describe that delayed progression, because some will say, oh, well, isn't the whole idea of curing? Well, we would love to cure, but we're not curing myeloma with 4 drugs, let alone one. But what has this now meant for your clinical practice? So, of course, we always say there isn't one simple way of doing everything, patient engagement, shared decision-making model with having a discussion with patients, because I'd be interested in knowing how you approach that. Because I can tell you, I know in my clinic, especially since Aquila came out, we've really been having some extensive discussions with patients. Some patients, when they hear the data and they understand they have iris smoldering myeloma, some of them say, doc, I really, really just want to keep waiting. Others say, hey, if this kicks the can down the road, I may never need treatment, or I'm not going to need it for the next several years while I live the best years of my life. I've just retired. I want time with my family. I want time with my grandkids. And others may say, doc, I think I might need more than the 1 drug. Let's watch and see if my disease is growing. I want to get the full 4. How do you approach that in your clinic? Are you essentially actively speaking to every high-risk smoldering myeloma patient now about the potential for treatment?
I think that we have to at least have this discussion. At a bare minimum, we have to have a detailed discussion about these data. Again, we had very suggestive data from the previous randomized studies, and now we've got Aquila. And the nice thing about Aquila is that daratumumab is a well-tolerated therapy. And although, not the formal analysis of overall survival, but we're starting to see a subtle overall survival advantage for those patients that received daratumumab versus active monitoring. Now, treatment paradigms are changing. Critics wonder appropriately what happens with CD38 antibody-based therapy when they convert to active myeloma. There's still some questions that people have, and they're important ones as well. And these are the kind of discussions that we have to have with our patients. I always encourage patients to think about it. And I am a strong advocate of multiple data points to better understand what's going on, when I first meet a patient. And I don't necessarily like to intervene until we're maybe about 6 months into observation, really just to determine, is this someone who's declaring themselves as active multiple myeloma very quickly, in which case standard myeloma therapy should be applied? Or is this someone who's really behaving, like a smoldering multiple myeloma patient where a single drug such as daratumumab may be advantageous? I think the one patient population that really makes a lot of sense to intervene is the patient who may have underlying comorbidities that would make a 3 or 4 drug regimen, transplant, extended maintenance therapy, et cetera, very difficult. If that patient is not going to do well with multi-drug therapy, daratumumab and kicking that can down the road, like you said, may be a very nice strategy for that patient.
I really like your approach. I mean, you're kind of distinguishing who's the fast and the slow runner, right? Because if that person's running
Right.
quickly, you probably don't want to give them a single agent. You want to fully treat them. So
Right.
I like that. I mean, obviously it's harder to do in a trial, and that wasn't done. Although, people, I believe they could not have had smoldering myeloma known at least for more than 3 years, because they didn't want to, include those patients that are what I call cliff runners. The ones alongside the cliff and never actually, thankfully, developed myeloma. But I think that strategy is extremely valuable. And of course, as we've said, engaging the patient and their partner, their family in the discussion is so important. I should just add the caveat here that we're still in a place where it's not FDA approved, but we anticipate response from that in the relatively near future as this is being considered. Pete, we have a few minutes before we wrap up. I just want to look to the future. So obviously Aquila is massively important. You noted that we're still waiting on a little bit more data over time for the overall survival element of it. But where do you see the future of smoldering myeloma going? I mean, is it really just going to be Aquila and that's it? Or There are other studies that are being done, more intensive approaches. We talked about the two philosophies of treatment. Are there studies where it's actually really quite intensive treatment to see if we can truly nix the disease and never get to slim crab? What do you see as the future of smoldering myeloma?
So I think first and foremost, we need to continue to improve the definition of high-risk smoldering multiple myeloma. And this where genomics and the immune microenvironment, I think, are going to be so critical. I think one of the criticisms that have been leveled on the existing randomized studies is the fact that it's a somewhat heterogeneous patient population. So there are people that you are likely overtreating. There may be some patients that you're undertreating, and then there are those patients that you're getting it just right. So how do we better characterize that group of patients? And I do think we will get better, especially with like whole genome sequencing and what have you. I think we will get better at defining, smoldering multiple myeloma and those who are at risk of progression to active disease. And there may be patients with high-risk smoldering multiple myeloma that wind up being recategorized as active multiple myeloma, to be honest with you, depending on what that data looks like. So I think that that's absolutely critical. And one of the reasons why we have to define it better is because of these more intensive approaches that you allude to. I think that kind of standard multiple myeloma therapy for high-risk smoldering multiple myeloma is a very interesting treatment strategy for this group of patients. But the question is, is it better than, the control approach? I mean, this is where we need the randomized studies looking at the gentle approach, the control approach versus the more intensive approach. Obviously, the more intensive approach is going to be associated with more side effects, right? But does it lead to better long-term outcomes? A good example of a study in this space is looking at lenalidomide and dexamethasone with or without daratumumab that's being conducted in the cooperative group setting, ECOG leading the way in the United States. And we'll see if the addition of daratumumab to a 2-drug platform will improve outcomes. And actually, the primary endpoint of that study is overall survival, as it turns out. There's the ASCENT trial, that was supported by the IMF. There's the CESAR study in Spain, really looking at aggressive 3-drug strategies and 4-drug strategies. And in the case of Spain with transplant, really promising early data. But again, we have to compare it to that control approach to see if it truly is superior and whether we're in fact curing any patients or not with smoldering multiple myeloma. I think what would also be kind of fascinating, kind of looking at, again, this whole evolving phenotype question, could we do a randomized study where we intervene for those high-risk smoldering multiple myeloma patients, are, experiencing evolution of their disease markers versus, treating them right out of the gates. So if you wait and just treat for those that are progressing biochemically, will we achieve the same outcome as if you were to treat them right from the get-go? I think that would be an interesting thing to look at.
It's amazing, right? I mean, I think what I'm hearing from you, of course, as we wrap up here, is that we have a lot of science still to learn, the better definition, the optimal approach, and that there are probably going to be different approaches that, depending on the patient and the scenario, may be best for them, that they could be quite different among individuals. I'm looking forward very much to the study that you mentioned and others. I mean, it's remarkable. We have some with daratumumab, some with cetuximab. The Harvard study presented recently giving CAR T-cell therapy to patients at highest risk of developing active myeloma. So I think there is a lot more to come in the space. I think we've covered this topic well. I guess my take-home message of should we treat smoldering multiple myeloma? The answer, of course, is it depends, and we have options. And discussing that with the patient becomes very important. I do think the Aquila trial is going to lead to much more treatment of high-risk smoldering multiple myeloma, and those other studies that you've mentioned are going to inform us much more along the way. So today we've had the privilege of talking to Dr. Peter Voorhees about should we treat smoldering multiple myeloma. Thank you so much for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on multiple myeloma. This is Dr. Joseph Mikhael for the Medscape In Discussion Multiple Myeloma podcast. Thanks so much.
Thanks for listening to Medscape's In Discussion Multiple Myeloma podcast series with our host, Dr. Joseph Mikhael. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes. links, and more information on multiple myeloma.